afternoon, everyone. Thank you so much for joining us for this evening's podcast. I am Athena McKay, the Executive Director of Flint Innovative Solutions, and we welcome you to Michigan Maternal Health My Mom podcast. A special thanks to you for taking time out of your evening to join us. Please do like and share this video with your networks so more folks can be informed. We are streaming live through Facebook, Instagram, and YouTube. Please use the chat to ask questions to our panelists today. I want to give a huge shout out to our fearless leader, Dr. Jennifer Johnson, who is leading the Miracle Center, which is Michigan's maternal health multi-level intervention for racial equity. This project is funded by NIH. At Flint Innovative Solutions, we have the opportunity to be the community PI on the project too, where we are developing a mobile app to reduce the risk associated with maternal morbidity and mortality. You'll hear more about the Michigan Healthy Mom app later. This evening, we have some very bright minds on our team that will be sharing with us. Dr. Claire and also Dr. Brian. Let me add them into the room. Claire, how are you this evening, ma'am? Oh, you're muted. You're muted.
Oh, I'm great. Thank you for having me.
Absolutely. Claire, get us started. How did you come about this work? How are you connected to the work? I know a little bit, but let the audience know so we can get familiar with you.
Sure. Yeah. So I am an epidemiologist. I'm in the associate professor in the Department of Epidemiology and Biostatistics at Michigan State. And so for the past about 13 years, I've studied maternal health over the life course. So looking at early life health, pregnancy, and now focusing on both pregnancy and postpartum health. And so I think that my earlier work and my research interests were mostly around pregnancy and infant health. But perhaps partially from becoming a mom myself, I realized how big of an impact pregnancy has on the mom and the importance of postpartum health. And so that's what I've been studying recently. And a big part of my work is trying to measure maternal health, just really get a better understanding of the issues and burdens on maternal mental and physical health in the United States. So that's some of what I'm going to talk about today.
Thank you, Claire. So you mentioned you became your mom yourself. Do you have how many children?
I have two daughters. They're 9 and 13.
Oh boy. Girls are interesting. As the audience may know, I share often. I have two boys, and my daughter is the middle child, middle adult at this point. And it's really interesting how different personalities, each one of them has their own personalities. And I think I see myself in all of them, but my daughter being a reflection is very interesting at times.
Yeah, I think they both reflect different parts of me sometimes that I don't want to see.
I know that feeling. We're going to give Brian just a few minutes to get out of clinic. So let's dive in. Claire, did you want to share yours? Are you okay to share your slides and get your presentation going?
Sure. Yeah.
Awesome.
Okay, I think there's a little lag, but there we go.
Awesome.
Okay, and I do want to say that every now and then my internet's like cuts out. So if I freeze up, hopefully I'll come back. If not, I'll log back in, but hopefully neither will happen. So as I mentioned, I'm going to be talking a little bit about how my research team, as well as many others, research groups, as well as state and national entities, are trying to measure and quantify what's being termed the maternal health crisis in the US. And so you've probably heard that term, maternal health crisis. It's been used in the media. There's a White House report on addressing the maternal health crisis. And so some of the statistics and numbers that are often used to quantify what that means, first of all, maternal death, so death during pregnancy or postpartum, is twice as likely in the US compared to other high-income nations. Here in Michigan, we have approximately 80 or more deaths per year, pregnancy and postpartum deaths, and it does vary over time, especially at least in the past decade when we have good data. But in the most recent years of available data during the COVID-19 pandemic, these deaths went up quite a lot. And reviews of these deaths by committees that are comprised of doctors and social workers and other experts that try to gather a lot of data about what happened and why this person passed away, have found that 75 to 80% of these deaths could have been prevented at some point. And so, this is one of the reasons that it's really important to do research both on trying to understand the causes of maternal deaths and also work towards preventing them, is because these are thought to be preventable deaths, things that we could do something about. So when you hear this term maternal mortality or maternal death, the official meaning of that is that those are deaths that occur during pregnancy or early postpartum that are somehow caused by the pregnancy, aggravated by the pregnancy, and that it does exclude deaths due to a lot of
Claire, are you there?
is to look at what are all the causes of death during pregnancy or the first year postpartum. And so we've looked at this using recent years of data in the United States. And as you can see, those causes that are related to pregnancy, so that's the bar labeled obstetric, that's the most common cause of death, but that actually includes a lot of different causes. So things like bleeding, hemorrhage, infection, and cardiac issues. The largest single cause of death is drug overdose, and that has been increasing dramatically over the past decade. And then you can see that there are also all these other causes of death, which are primarily motor vehicle accidents, and then there's homicide and suicide. And so another really important thing that our team has been trying to measure is how the burden of these deaths differs across different groups, and try to understand who is most at risk, and then of course to try to understand why that is. So we have looked at racial and ethnic disparities and inequities in these causes of death. So this is just showing those same causes of death, but broken down by the race or ethnicity that's identified on the death certificate. So you can see that people who are identified as either American Indian or Alaska Native or non-Hispanic Black are at much higher risk of those obstetric deaths. American Indian and Alaska Native people are also at a high risk of drug-related suicide and other causes of death. And then non-Hispanic Black people are at the highest risk of being victims of homicide during pregnancy or postpartum. And so these are really, unacceptable inequalities that need to be addressed. We've also looked at differences by where people live based on whether they live in an urban area or a rural area. And you can see that for all of those causes of death, people living in rural areas have the highest risk of all of those causes of death. So it's really important to think about, why this might be, and to be sure to note that this isn't because of individual characteristics for the most part. It really has to do with the context of where people live. So this is showing a map of this measure that has been created to capture maternal vulnerability. And what that means is that the darker areas are areas where this measure is based on measures of things like access to reproductive health care, access to general health care, social determinants of health, physical environment. And so you can see the darkest areas are the areas where those resources are least accessible and where the environment is less health promoting for maternal health. And so you can see that those areas in the South, going up into the Midwest, and in rural areas across the nation have much higher levels of this maternal vulnerability. And so that's very important to keep in mind in terms of understanding why there are these unacceptable inequities. So it's another thing that is important to note, and that my research team is trying to get a handle on, is that the maternal health crisis is much larger than just these deaths. And so deaths are really just the tip of the iceberg of a much larger set of issues. And so this is a graphic that was developed by another group that reviews maternal mortality, and showing how there are many other measures that are more common than death. So that's why the pyramid gets larger at the bottom. So it's showing that, for the most rare case, but for every death, there are a larger number of what they call near misses. So that's when there's a severe outcome of labor and delivery that doesn't result in a death. Then below that is severe maternal morbidity. Those are outcomes of labor and delivery that cause short or long-term health problems for the person, the pregnant person, or the person giving birth. So that includes things like hemorrhage, infection, and preeclampsia. And then below that are what they call maternal morbidities, which is just a term for issues that either require hospitalization or an emergency department visit or a primary care visit. And so then this part of the pyramid, in my view, is also taking into account health issues that are not just those related to pregnancy, but some of those other things I talked about earlier. So substance use, perinatal depression and anxiety and mental health, intimate partner violence, all of those things could result in emergency department visits or primary care visits. But then I think what's missing from this pyramid is another big layer, all of the issues that don't result in any kind of healthcare interaction, and all of the physical and mental health issues that people may be having during pregnancy or postpartum that they don't get any kind of care for, and that go unidentified and untreated. So there are some measures of some of these issues, although I think this is really like we're still trying to get a handle on all of these different measures. So maternal morbidity is one of the things that we do have a good measure of. So again, that's things that happen during pregnancy and labor and delivery that have shorter long-term impacts on the mother. And about 1 in 50 mothers in Michigan are impacted by one of these types of things. And we also know that severe maternal morbidity is increasing over time. So you can see this is just the red line is just showing measures over time. And you can see that it starts to increase quite a bit between like 2017 and 2020. So we don't really know yet whether that's increases in measurement, that like these things went undetected prior, or if it's truly an increase in severe maternal morbidity. And then this is some recent data that came out showing that diagnoses of perinatal mood and anxiety disorders are also increasing quite a bit over time. But as you can see here, they've really increased a lot since the Affordable Care Act, which expanded insurance for a lot of people. And so this could be the fact that as more people get health insurance, they're more likely to be able to get a diagnosis of a disorder that may have previously gone undetected. So I think a takeaway from all of measuring these things is very difficult, and we don't have all the time, we don't always have the data that we need. And so my research team is working with emergency department data, trying to estimate trends as well as disparities in emergency department visits during pregnancy and postpartum, due especially to drug use, self-harm, and violence. And this is just a little bit of that data from California. And so the main line that you see, the big gray line, is showing that overall emergency department visits during pregnancy and post related to drug use actually declined. But what we don't have here is data after 2018, which is when the fentanyl crisis really started to kick in California. And so we, with more years of data, that we'll start to see increases in these drug overdoses during pregnancy and postpartum. So I think probably anyone who's listening now is just wondering, like, well, what can we do about all of this? And so this is, I don't expect anyone to read all of these words, but this is kind of a framework for thinking about what we can do and where we can try to intervene to improve these poor maternal health outcomes. And so this is categorizing those potential areas for intervention into areas that are related to the patient or the person themselves. So things like health behaviors, knowledge, social support, social determinants of health. The second category is thinking about the community and neighborhood that the person lives in, and how does that affect their social support or their ability to access care, or their psychosocial stressors. The third category is thinking about the providers and what factors at the level of healthcare providers could be intervened on. So thinking about improving healthcare providers' ability to see early warning signs of maternal morbidity and mortality, increasing communication, reducing implicit bias. And then the final category is system level factors. So thinking about how can we improve access to high quality healthcare, transportation, thinking about structural racism, and thinking about policies that might improve maternal health. So I thought I'd just mention, and I think we're going to talk a little bit more about this as we go forward, but the project that all of us that are presenting and talking today are working on is the Am I Mom app. And so this is the Michigan Healthy Mom app. It's a phone app. And so the goal of this is to reduce pregnancy deaths and complications with a focus on helping Black and rural moms, as I showed those disparities. And so with this app, we are hoping to develop content that will help pregnant people, their support people, as well as those healthcare providers to be able to improve their health, know what the early warning signs for morbidity and mortality are, get additional support within their communities, et cetera. And so again, this is a lot of words, and I don't expect anyone to read them, but we are trying to address risk factors within those categories that I showed before. So we have a set of risk factors at the individual level, at the level of a pregnant person's support people, so their partner, their mom, their friend, at the provider level, and at the community level. And we have elements of this app that we hope will address risk factors within all of those levels, because this really is a multi-level problem. People are being impacted by factors at all of these different levels when they're pregnant and after pregnancy. And we really need to address all of those factors at the same time. So that is all for me. I did put my email here in case anyone cares to follow up with me later.
Thank you so much, Claire. We'll leave that out for just a bit so everyone can have the opportunity to jot it down. Also, if you have any questions, please drop them in the chat so we can address them as well. That's a lot of information. I'll just, some high points. You said at least 80 folks die a year through these complications, and probably at least 75% of it is preventable. That's
right. And that 80, I mean, that's in Michigan alone.
Yeah. Thank you for that. Thank you. And this is not a laughing matter, but when I looked at the map, I'm like, maybe I should reconsider going down south to retire, because the southern states, all of that, all of their numbers were staggering as far as the number and the percentages of complications and death with pregnancy.
Yes, and yeah, and I think that one of many things that's driving that is access to quality healthcare. One thing that we know is that in rural areas, and this is a big issue in Michigan as well as many other places, rural hospitals are not able to keep open things like labor and delivery. And there's shortages of providers for both obstetrics as well as mental health, substance use treatment, etc.
Thank you, Claire. We do have our other panelists in with this. So, Brian, good evening. How are you? Oh, you're muted, sir.
Hi, how are you?
Doing well. Thank you so much for joining us. I'm quite sure you could piggyback off of Claire's presentation pretty easy. But if you could give us a little introduction to yourself so that the community can become familiar with you.
Sure, absolutely. So I'm Brian Tessler. I'm an OB-GYN by trade. So I work as the System Chief Medical Director for the Women's Health Service Line for the McLaren Health System in Michigan. And what I do there is I try to bring all of our hospitals together. We have 13 hospitals and 9 birthing centers that offer services to our communities throughout Michigan. And my job is to bring them together and to try to increase safety, equity, and give the best possible care to patients and make sure our communities have what they need from us and make sure they're getting the services that they need. One of the big things that we do is we are very immersed in our communities. The way that McLaren has grown itself is by entering into communities. And we love that unique feature that we're embedded within our communities. But we also serve a lot of communities that are really in need of especially maternal care. And those can be anywhere from getting close to maternal deserts, which means there's literally no care for a reasonable amount of drive for a pregnant patient, to those that are in the low access areas where it's an extensive drive or hard to get care in those areas. So we do serve a lot of the areas that really need obstetric care. I think it was mentioned in the previous presentation that access is a problem, and that's something that we're trying to help remain and keep in those communities that we're at, because there is a lot of rural and smaller communities that are losing their birthing centers. They're closing left and right throughout the United States with different reasons, but really the cost and liability of obstetrics drives a lot of that. And that's because we need to understand better what we can do to make safer and more efficient care for maternity patients. But that's what I do for my day job. But I am an OB-GYN, so I do see patients off and on as well. And then I do work for Michigan State University in the Office of Diversity and Equity, and I do curriculum review for medical students. So that is my other half.
No wonder you've been a little busy and hard to get a hold of. Brian, would you happen to be a dad too? Have you had personal experience with?
I didn't birth anybody, but I always say I catch, I don't birth, but because that is a very special privilege. But I do have a 14-year-old teenager, so I'm out of the baby market, but I have a 14-year-old, which is a whole different world of trouble. But he's a great kid.
Awesome, indeed. Well, thank you so much. I'm going to bring both of you into the conversation. As we know, this is a very, very serious issue. Um, and I want to point us a little bit towards how we all got connected, which is the My Healthy Mom app. Brian, I'll start with you. As you know, as one of our community advisory board members, and as Clara shared too, there's multi levels that we're trying to approach the patient, their support person, so systems, and the health providers. You being a health provider and overseeing birthing clinics, could you share your thoughts on how impactful you believe we're hoping this app could be?
Absolutely. We don't have time. That's the biggest problem. We don't have time. We have so many things that are demanded of our clinicians that are out there, be it a midwife, be it a physician, be it a nurse, or even medical assistants now. There's so much demand on the time that is in the clinic, and the patient care is getting narrower and narrower because of that. But the complexity of taking care of patients is getting harder and harder, because if you come to me with a whole bunch of issues and problems that haven't been addressed, I've got to activate as many systems as I possibly can. And that's got to be a lot of resources and a lot of other things that take place. And some places are set up for that and some aren't. But if they aren't, it's a very large stressor. But again, I think the time component to it is really, really hard anymore. I think most people know a prenatal visit with a doctor nowadays usually looks like, you're leaking, bleeding, contracting, cramping. If not, baby moving, great, have a great day. It's 5.5 seconds. We do your heart tones and you're good to go. But the time that you sit and wait in the office and all those other things around it are very inconvenient. And I think that's time that we, could have been doing something, could have been utilizing resources, and helping our patients to understand in between the visits what's going on with them, and to help educate them for things to look for themselves. But I think this is the arm, the extension that we've needed as clinicians, that ability to just give our patients something that they can literally interact with and understand and get the message that they want. And I do have a grant program with a women's health nurse navigator in the Flint Family Medicine office. And that has become so immensely, it's just easily understood that people are starving for information and they're starving for advocacy. And just putting that in place has helped so many of our patients just have their questions answered. Because it's one thing to ask a nurse or to ask somebody that you can easily connect to and access as a patient, than to ask your doctor. Because some people feel like, oh, I don't want to waste their time, or I don't want to ask something silly that everybody else probably knows and I don't. And I think that's another piece that is really important about these easy to connect like apps and resources. Because it lets people feel safe about the information. Like they know it's coming from a good resource, but it's also something that, they're not going to be judged for looking at and talking to and telling it, I might have this issue or this problem, and getting resources through that. So a lot of reasons, but I think it really will be the extra arm length that we need and that extra time we need with patients that we just don't have anymore.
Thank you so much. Claire, I'm going to pass it over to you. You shared a lot of information about drug overdose and substance abuse. How do you see the app being beneficial in helping combat those ills?
Yeah, well, I think that one of the biggest, hopefully, benefits and ways that we'll be able to help people is to connect them with resources. So, we will be asking people what they know and giving them information about how substance use during pregnancy can be detrimental for your health and your baby. But I do think most people know that and are in need of resources to support them on that journey. So we will be connecting people live on the app with a community health worker who will be able to connect them to resources in their community that can help. And the idea and the hope is that community health worker will be able to connect them also live. So instead of just saying, call this number or here's this website, they'll actually do that work of connecting them, reaching out, and getting them, an appointment or whatever's needed to get the help that they need.
Thank you, Claire. Brian, I'm going to pass it back to you. You mentioned, I believe, 9 clinics that you oversee. Can you share where those are? That's a tremendous resource to community members.
Yeah, 9 birthing centers. So that's our labor and deliveries that are available to our patients. There's many more clinics than that, way more. But each of our communities that we serve right now, so I'll just kind of bring you around the state and go up. We're kind of focused towards the thumb region, and then we expand upward from there. So we have Macomb, which is down in the Detroit area. And then heading up from there, we have Port Huron. Port Huron over to what we put together as Caro Thumb, which is kind of that upper thumb heading towards Lapeer area of the thumb, which is a very, very sparse area for care. And then we come back over to Lapeer. And then from Lapeer, we would hit Flint. And then from Flint, we could go to Greater Lansing, which is our newest hospital, just built in the Greater Lansing area. A lot of great things going on there for maternity care and high-risk pregnancy care. And then we also come from there, we would go up, and then we have Bay City. Then we have our Central Michigan location, which is in Mount Pleasant area. And then we shoot straight up to the very top in Petoskey, which is our crown jewel up there on top of the McLaren hand. So we're pretty spread out, but as you can see, a lot of our areas serve really high critical access areas. And I know on your map that was shown in your presentation there, there's also some correlation with Native American and Indian health services that go with those really bad maternal care issues. And Central Michigan is located in Mount Pleasant, where we do service some Native American tribal members there. And that's where we're also trying to look at is if we are serving those areas and what we can do to improve in those regions as well. So I know that's some correlation with those colorings on the map as well.
Thank you so much, Brian. The other thing that I really want to touch on, and you both being in the field know how critical mental health is. Would either one of you like to share some of the resources and some of the things that we're intentional about in regards to addressing mental health?
I can start out in, McLaren is really taking a huge dedication to women's health again. We've always, been a women's health hospital. Margaret McLaren, the hospital is named after a nurse, Margaret McLaren, and she was a women's and children's nurse. So I always remind people we've been this since the beginning. But it's something that, we're really kind of taking on. And that's where my position came from. It's a newer position. It was literally created from this, fact that we have really bad maternal morbidity and mortality. And, my head chief medical officer for the entire system, Dr. Clamaris, said, we've got to put somebody to help us figure this out because we can't keep just saying it's good enough. We got to fix this. And that's where we put a lot of commitment back into our women's health services or OB-GYN services. But, one of the things that we found that was a huge problem is mental health access. And mental health is becoming one of the, and you can argue it one way or the other, one of the largest killers of our patients in maternal care. And this is, if not a huge morbidity issue, but, access to services is such a problem. And, then if you have a patient who's actually pregnant, finding them inpatient care is like close to impossible. I've literally had patients, not in McLaren, but in my care before at other systems that I've kept in the hospital for 15, 16, 18 weeks just because we couldn't get a bed anywhere. So we utilized our antepartum, labor and delivery unit as, a unit. And that's just because we couldn't, let that person go out and be unsafe. They had to be taken care of. So we've used that before, but that's how hard it is to get those spots for people. So adolescents, and if you throw adolescent on top of pregnant, it's just, you're not getting anywhere. So, communities that really need that are not getting it. And that's a huge problem too. But we have a line leader as well in our mental health services, and they've committed to making sure that we look at and try to expand our services for women and those seeking maternal care through our services. But it's never going to be enough for where we're at now. But I think that the big thing is if we keep talking about it, we can help normalize and destigmatize it, because we all know mental health has a huge stigma around it. And then you add on top of that the fact that someone's just become a parent, maybe for the first time or even another time, and they have all this expectation on them of being able to do everything perfectly, even though there's no book and there's no manual, and they don't come with off switches. So it's just, you have all that pressure and all that expectation. And then, you know, like we talk about a lot of times, my nurse navigator is a lactation expert. And we talk about, we have patients that come in and just start bawling because they don't think they're doing well enough with breastfeeding. And people are like, oh, you're fine. But if you think about the fact that that is like, you literally think you're not able to take care of and feed your child. I mean, that's not like I can't afford them the new video game system. I can't feed them. You know, there's no other way to feel so inadequate and so incapable. And where that takes people in their minds, I can't even imagine. But, you know, it's like those are the things that we're not clicking with. And, you know, there's a lot of, unfortunately, and I'll close on this, but my biggest thing is I see this all the time in our area of care. There's a lot of, oh, it's not that bad, or I had that too, or, oh, so-and-so had that, it's not a big deal. There's a lot of blow off of these things that these people are trying to say, like, I think I have a problem. I think something's wrong. I think I need help. And we just kind of blow it off. And then when people get to the severe side of things, it's not very fixable at that point, especially when you don't have resources. So that's a huge issue there. But we're trying to build resources and get better at that. But that's something that's really hard to do.
Thank you for that, Brian. I know my experience, I didn't have any complications through my 3 births, but nursing was not, it was taboo in my upbringing, in my culture. And so I did a lot of research to figure out the benefits. And again, I didn't have any trouble with them latching on or anything, but through this work and talking to other community members, and hearing the data and hearing the heartbreak of, you know, losing your child or not being able to feed your child, it's very dramatic. I can put myself in, we can try to put ourselves in someone's shoes, but that was one of the most intimate times where I was able to just, you know, bond with my children. And for a mother who is trying to do the right things and trying to be perfect, like you mentioned, that can be very devastating. And especially if it's just blown off, or why are you trying anyway? Just go get some, you know, some Infamil or some, you know, all of those things. So thank you for bringing that up.
Yeah.
Claire, you want to address the question as well?
Sure. I mean, I would echo everything that you've both said, and I guess I can add a few thoughts that are in my mind. So one thing that comes to my mind when we're talking about this is that I think, like, a lot of the what people hear about is baby blues and then postpartum depression, and then, but I think that we don't talk as much about postpartum anxiety, which is a really, I think, a big issue as well, and maybe even harder for a person to identify, or maybe for their support network to be able to see, oh, you're struggling. And I think it's related to some of the things you said about the pressure to suddenly take care of this thing that you have no idea how to take care of, and that there, you know, those societal pressures to do a good job or a perfect job, or which doesn't even exist, are so huge. So, I mean, that's just a recipe for anxiety, as well as, you know, all the hormonal changes that are going on. So that's one thing that comes to mind. I think a positive note, I guess, or I don't know if it's a positive note, but it's a resource that I could share, is Postpartum Support International. So it's a website, but you can find providers in your area. In some areas, you can reach out to, like, the local contact who can help link you to mental health providers. Of course, the demand is greater than the supply. So even though that resource exists, and, you know, people should access it, there's still not enough mental health providers, especially that specialize in pregnancy and postpartum. And then I think the third thing that I'll say is that an issue that I'm really passionate about, and that another part of my research is trying to address, is just the lack of any real, you know, safety net or public support system for or mothers in the US. I mean, I think it's just, like, so shocking to me, like, just even on a personal level, like, what I am expected to do with no support. You know, like how are you supposed to earn money and take care of a child or a baby? It just doesn't add up. When, you know, getting someone else to take care of the baby is exorbitantly expensive. But then somebody's got to pay the bills. So I think that like the public policy landscape is extremely unsupportive and really contributes to this mental health issue.
Thank you, Claire. I agree. We have some serious challenges. And I've shared this on a couple other of the podcasts. Being a teenager and undergrad, that was the furthest thing from my mind. It was not on my goals. I did not want to be a parent and bring a child into this really wicked world. Fortunately, I had the opportunity to, and we have an opportunity to make the world a better place through our work. And they're actually a part of that work as well. We have about 15 more minutes. Brian, is there anything that's on burning on your heart that you want to share in regards to where we are in the industry, a plea for community to take better care of themselves and support policy?
Yeah, absolutely. You know, it's said about me that I don't have a soapbox. I have a soapbox factory. I can get on a lot of things. But, you know, I think where my passions lie anymore is really focused on the fact that we have such a problem with being able to talk about problems. That's kind of the one of the big things that I really hate. And giving people the empowerment to say that something's wrong, and allowing them space to do that, I think is something that we really don't have. And I'm really looking into that. I'm really interested in finding something like that. Like Claire mentioned, a safety net. Like there's just nowhere they can fall to. You know, it's just survive or die, unfortunately, you know, with a lot of these situations, and it's very sad. But I think the big things I'm looking at lately is, you know, when it comes to access, it's like great if you have something near you, right? And that's wonderful. But if that thing near you is only appointments until 4 p.m. and you work somewhere where you don't get PTO or you don't get flex time, because that's rare, that's not a thing everybody has. Even in the, you know, higher or lower level of jobs, it doesn't matter. Everybody doesn't have that. You know, and you're going to an appointment that you're seeing somebody for a leaking, bleeding, contracting, cramping visit, and you're in that waiting room for 45 minutes. You're in the office sitting in the room for 20 to 25 minutes. And then, you know, you wait for somebody to check you out for 10 to 15 minutes. That person's missed almost a half day of work for a labor, you know, just a regular routine OB appointment. And if this is a healthy, otherwise person, that is so much of their time consumed that did not need to be consumed and did not need to happen that way. So it doesn't matter if you have something 2 blocks from where you work or where you live. That's not what access means. Access means meeting patients where they are and what they need, and making sure you're serving them in the way that's going to actually make a difference for them. And when I hear, you know, like you see the new March of Dimes data from 2023, and you see that people are like driving like 30 to 40 to 50 miles to prenatal care, like that blows my mind. And then when I go to an appointment, I'm like, oh my gosh, I'm the biggest, most horrible person for seeing you for like such a small amount of time, you know, knowing what they've given up and what they've sacrificed to be there, you know, from their day and their time. And then, you know, you've got people who like, you do that appointment, you try to do it at like 3 o'clock so you can, you know, not miss much work, but then they've got kids in daycare. And daycare, I'm running the wrong business. Like I need to own a daycare. Like, do you know what these things, I'm sure you do. These things are out of like, and if you own one, I'm sorry, I don't want to offend you, but like go you, but like, this is like a lot of money. Like 10, 15 minutes is like time, money. Like it's like a parking meter, but like really expensive. You know, and I'm like, this is like crazy what these people are paying in childcare costs. And, you know, it's like, everybody's like, yay, have a kid, you know, we'll be here to help you. But again, where's that policy and support system? It's not there. You know, it's not there. And, you know, like, I don't care where anybody stands on any, that's yours to stand on your issues where you want. But who's answering these questions for these people who have these babies and have these kids and have these children? Because you can say you're going to support them all you want, but you're not. And like I tell my new parents, like I tell them, when people come over after you have this kid and they're like, let me hold the baby, you say, do a load of laundry or do my dishes first, then you can have this baby for an hour. Like, you use that baby as a bartering tool. And if you get them out of your house, because like I'm thinking, like I've got patients who are like 19, 20 years old, they're living in an apartment, they already got one kid, they have this baby, and like no one's there to help them, but people want to come over and like hang out with their baby. And it's like, you can change a diaper, you can go take the trash out, you can help me out if you really want to help me with my baby or see my baby. But I tell them, use that baby as a bartering tool all the time. But that's like forcing a support system. But and that's just in a situation where someone has someone coming over. We don't even have that for a lot of our patients. Right. But that's also something where I'm looking at, like doula services, and also meeting communities where they're at with providers that look like them, people in the birthing business that look like the people they're serving and have cultural connection to who they are. And I mean, I try to be part of everyone's world as much as I can, but I'm also very aware that I'm not. And, I know there's parts of the world I can interact with, and I know there's parts of the world that I can't. And when I go to a labor and delivery unit, the first thing I always do is I look at the unit and then I go meet patients. And I want to see how much you match that unit in those rooms. And to me, that is such an indicator of whether we're meeting our community where they're at or not. Like that's such an easy temperature test to see if we're meeting that need. And when you're talking, one of the biggest things that's a problem for people getting medical assistance and help in pregnancy now, or not wanting medicalization in pregnancy, is trust. When you have that clash of not meeting your community where they're at, the trust isn't there. They're not going to come to you. They're not going to want to, do things with you. And if they do, they'll have a bad experience and then they'll never come back again. So that's something that I'm really looking at as well too. And that's where I think doulas are so priceless and so important to this process. And I know, like, as an OB-GYN, some people will probably like explode in fire for me saying it out loud, but like doulas are those patients' community. And they are usually from their community and they understand their community, and they're there to be that voice of that person for that community, and be that connection where you can't be connected. And I think that's just such a vital part of it. And, the fighting and aggression in that situation comes from the fact that we create it, and we need to just realize that if we just all hang out and be there for the person that we need to be there for, it usually goes pretty well. And that's something that I think we can make that connection with. But I don't even know how many I just got off there, but go forever. But I'm very passionate about what I do. I really love what I do. People ask me all the time why I'm an OB-GYN. I honestly don't know. I guess I'm a mama's boy, but I really love taking care of the people I take care of and doing what I do. And, as much as I hate 3 a.m, because that's when all babies want to be born, as much as I hate 3 a.m, I will never, ever leave a birthing room upset about it, because that moment, that human moment, that engagement, there's nothing like that. Birth and death are just the most beautiful experiences to be with people in, and to have people to give you that honor and that privilege to be in that moment, and to be the first human to like usually touch those little beings in this world, and be those first hands to be there for that kid. Like, that is a great thing to be part of, and it's amazing, and it makes me so happy for what I do. And you were talking about like this evil, ucky world. And I think about that stuff constantly, right? It's on all of our brains. We can't stop, with the way things are now, we can't stop. Doom scrolling is automatic. I think it's chipped in our heads now. But when that kid comes out, when that baby comes out and I have it, I'm like, this kid has no idea of race or creed or gender or orientation or policy or party, or like, that person's pure. Like, at that moment, they're pure. And that gives me hope for human race, because that tells me at some point in our lives we can be.
Yes.
It's taught, it's built in, it's given as a really bad gift, a lot of these things to people as they grow and they are part of the world. But we all start without it there. And that gives me hope, because that means that the base zero setting of us, we can be that way. We all can do it because we're not born with those things. At least I haven't seen a kid do any kind of like inference of that yet, but could be. But there's I'm off. There's my soapbox. I'll jump down.
So it's not an anomaly that both of my children were born at 3 a.m.
Oh no, they love it. I love it. They think it's hilarious.
Yeah, now they want to stay up on their birthdays until 3 a.m.
Brian, thank you so much. I appreciate your soapbox. I did jot down some notes. I think my pen ran out of ink, but I grabbed a new one. And these are all critical things. And I would concur. When I first heard the heartbeat, and that was not my heartbeat, it was like, whoa, this is transformative. And I literally went from being an undergrad, post in my master's degree, graduate student, to taking on the world to say, okay, now I need to create a world, and it really enlightened me. It changed my heart because I heard this heartbeat and able to even now, I shared on one of the podcasts, my son will be 26 in August, and he just had oral surgery yesterday. And here I am, mama. I'm like, let's give me some groceries. You need some soft foods. It doesn't end. And it's a joy to be able to be connected and to be able to be a part of that growing and nourishing and evolution. So I wholeheartedly agree. Claire, we got about a few minutes. What you got for us? Let me get a new pen and we will get going.
Well, I could talk about the postdoc thing if you want me to mention that before we're done. I don't know if that's what you had in mind, but we were going to mention that the project that we are working on is looking for a postdoc. So this is someone who's completed a PhD in a related field, which could include psychology, public health, health communication, epidemiology, or something else, and who wants to join our team and do research related to the My Mom app that we're developing and will be testing, and to do research on pregnancy, morbidity, and mortality in general. So you can reach out to any of us or look it up on careers on the MSU careers website.
Thank you for that. I before we close, I do want to present one more thing as well. As you mentioned earlier, we have the Michigan Healthy Mom app. We're also looking for testers to be a part of those interventions. So we have about 5 teams that are competing for $5,000 over the next 5 weeks. They are getting trained on the software, also have office hours with our technicians and our professionals at MSU. But once those interventions are created, we'll need folks to test and judge those. So I am going to share our website. The link is here at the bottom of our screen, but we also have a phenomenal website where you can, moms can go, not only moms, but anyone interested in being, that's not the right screen, sorry. There we go. You can go to www.pc-pramm.org/Flint testers. And we are, again, looking for folks to review the interventions that are created by those that are competing in the appathon. We're looking for anyone that has first or second, so the commitment is between June 25th and July 1st. We're only looking for about an hour of your time. It's a $25 stipend for your time. You must be 18 to participate, live in the greater Flint area, not be a competitor of the Apathon, and also not be employed by Flint Innovative Solutions or Michigan State. And this is the form here on our website. And again, we're looking for those who have been pregnant, are partner of a pregnant person, a close friend or family, a healthcare provider or pregnant patient, which includes a doctor, midwife, doula, or nurse, and you have not been pregnant or provided care for, or even if you haven't been pregnant or provided care, we would still like your input if you meet some of this other criteria. So please take a look at that information, and you can participate in the Apathon by being a tester and a judge as well. So we have 4 more minutes, and I'm very thrilled to be able to have both of you on the panel today to share the data, to share firsthand experience, and that livid example of birthing a child, Brian, being on the other end of it. Any closing words? Claire, I can start with you.
Sure. I guess I could just close by saying that I think it's a wonderful thing that this project is part of a much bigger nationwide effort that's funded by NIH to try to address these issues, specifically racial, ethnic, and rural disparities in maternal morbidity and mortality. And there's, I think, 7 or 10 centers all around the country, geographically dispersed in focused on different communities, trying to address this issue. So I presented a lot of sobering information. I do think that there are a lot of people who are working hard to improve this problem in Michigan and across the U.S.
Thank you, Claire. Brian?
Yeah, I want to take this opportunity to thank people like yourselves. We do what we do, but I think it's just so awesome to see this massive effort to just do better, and just get things to be better for the patients that seek maternity care and need maternity care. And, it's innovative, it's new, it's smart. And I think that's just really, really cool. And I think it's just so nice to see the community piece, that the community's involved in creation and understanding of it and being part of the moving forward of it. But I really appreciate those that do the things that we can't, because we're doing our thing, but, and I know our thing helps, but it's all those things that when people leave my office that I can't do for them anymore, or I can't help with, or I can't connect for them. I want to go home and cook everybody a meal or things like that, but it's just not realistic. But if somebody gets resources to help them with those things, that's a win, right? So I think this is something that really is important to me, and I just thank people like you for doing it.
Thank you so much, Brian. That brings us to the close of this podcast, data, details, and delivery. Thank you so much, Claire and Brian, for presenting. As you can see, it's going to take a village. Our hashtag for this event is Be the Village. It's going to take all of us to make impact, from the patient, from that mom, from their support system, the system itself, the healthcare system, as well as the healthcare providers. So please do be a part, be a tester. We'll be having another Apathon in rural community soon. And so with that, thank you again for taking time out to share this, to view this, and please share the information so others can be informed and catch the wave. Take care, everybody. Thank you.
Thank you very much.
Thanks, everybody. Bye-bye.